Okay, I think we'll get started. So my name is Akila, and I'm the founder and CEO of Medvocate. And this event is actually happening in partnership with Screen to Succeed. So Trisha actually reached out to me about wanting to do this event, and we're super excited to be, doing a virtual shadowing event with Dr. Liu. And he will be speaking more about his background, but I don't want to take up too much of your time. We are going to be doing virtual shadowing today. So towards the end, we will be putting a quiz link in the chat, and if you get a score of 2 out of 3 on the quiz, you'll be receiving a certificate after. And Medvocate is basically an organization where we do a bunch of different virtual shadowing events, and you can find us on Instagram, and we also have a huge Slack community, so I will be putting a link to that later. But I'll let Trisha introduce Screen to Succeed right now.
Everyone, my name is Trisha, and I'm just so excited to partner with Medvocate to bring everyone this event today. I run an initiative called Screen to Succeed, which helps raise awareness about cancer disparities among low-income and minority groups in cancer care. So we hope that today's presentation exposes you to some of these ideas and helps you learn more about the field of oncology in general. So thank you all for coming today.
Yeah, hi. I'm happy to be here to have a little bit of discussion with everyone. Yeah, I'm Hongtao Liu at the University of Chicago. I will give you a little bit of background on myself. Then, I may talk about some inequality in the healthcare and how we improve. Then maybe we'll have some case study regarding acute leukemia. I didn't prepare the question. I hope they prepare the question. You also 3 questions, but I don't have questions for you. But you can ask any questions. So I'll just give you a little bit background of myself. I'm a little bit different. I'm an immigrant from China. I got an MD PhD in China. That came here initially as a postdoc at the Northwestern for 7 years, and did the research. Then later I decided to take the board exam and did my residency in the small program in Texas. Then I came back to Chicago and did a fellowship at the University of Chicago. After that, I stayed as a faculty, and started ranking as an instructor. Then you promoted to an assistant professor. Recently, I was promoted to associate professor of medicine. I was also named the Chicago top cancer doctors for a couple of years. And also this year, I was named the Chicago top doctor by Chicago Magazine. Yeah, so, you can find my information at the UC Medical Center website. Basically, my academic interests try to develop a new treatment, and especially using the body's immune system to fight the cancers. And I have some fundings from the different organizations. My clinical interest actually specialized the diagnosis and treatment of leukemia. A lot of people may never heard leukemia, and also I do stem cell transplant and also cellular therapy. Right now it's a very hard area and provide some cure for a lot of patients not curable in the past. I will give you a little bit background about my, what I do right now, distribution of the time and effort, and by the end of the day, it doesn't matter what professional you will be in, there's always some, time and effort. And right now, my earliest time, I have some project research time. I have grant. At that time, I have like 50% research and even 75%. But right now, I'm a transition to the more patient care, 75% of patient care, 3.5 day outpatient clinic, and 10 to 12 weeks inpatient service, and working with the resident and middle level physician assistant and fellows taking care of leukemia patients and stem cell transplant patients. Still do the clinical research. I will discuss a little bit and conducting clinical trials, try to find a new treatment, and also doing some translational research. Also, as I mentioned, I work with the medical student, the resident fellows, and the physician assistant, provide some education The other part I also do some administration, because as part of the director of aphesis unit and cell labs. As I mentioned, my main academic interest is to improve the care of patients with hematologic malignancies, especially in the population of minorities. I saw a lot of African American, Spanish, and Asian patients, and try to develop a novel treatment for patients with leukemia. And majority of leukemia can enter remission, but they always have relapse, and that's why it's not a cure. And my main focus on try to prevent the disease relapse and to have a lot of clinical trials, clinical research, try to prevent the disease relapse. I have a lot of, as the clinical researcher, we always do clinical trials, try to develop new treatment. I had like 8 investigator-initiated trials in the past couple of years, and most of the trial already finished and presented. And last month, I just had an oral presentation at ASH and American Society of Hematology meeting, national meeting. Though I'm also PI of the national trial, and to use the immunotherapy, try to prevent the disease relapse after chemotherapy, the leukemia. We already finished the enrollment. I hope the result will be mature enough to be presented at the national meeting later this year. That's the trial actually conducted all over the country at more than 40 centers. We already finished the enrollment, so right now we just wait for the data to mature to present the result. As I mentioned, I'm doing a lot of clinical research. Clinical research, that's 2 parts. Most physicians just run the trial and initiated by the pharmaceutical company like Merck, BMS. Always try to get some drug approved. Then they have to do the phase 1, phase 2, phase 3 trials. Most of physicians just enroll the patient to the trials. But sometimes you want to have some idea. You work with the company, try to have initiated the trial. They call it investigator-initiated trial. That's a part of the research. So the question is why I choose oncology. Cancer now is one of the top killers, actually surpassing the heart disease. Heart disease, stroke used to be very bad, and renal cancer patient live longer. Everyone live longer because of the care for the other disease, but more patients actually are dying cancer. And also the treatment options have been expanding in the fascinating speed. A long time ago and 20, 30 years ago, and the treatment we very limited. We just taking like care and the supportive care. But right now, with understanding of cancer biology and the new technology, we do have a lot of treatment options. And the death rate from cancer has been decreasing. Survival of the cancer patient has been increasing. And also there's a lot of new treatment available, targeted therapy, immunotherapy, actually are replacing the traditional chemotherapy, and some leukemia could be cured with the chemo-free. We don't need chemo anymore. And more patients will be cured. And right now it's very exciting time actually for oncology. And also a lot of physicians will tell you oncology has the best relationship with the patient because we see them all the time. Like my transplant patients, in the first 100 days, we see them 2 or 3 times a week. Basically you are part of the routine for long period of time. There's a lot of challenge. Also, most cancer patients will still die from the cancers. The physician needs to deal with death personally, emotionally on a daily basis. And also due to the high cost of cancer treatment, the social financial burden for the patients and the caregivers are very high, and the physicians also are facing these difficulties on a daily basis because you are not only taking care of the disease, you have visit, you know that what they are going through. It's not easy. I have a lot of patients and have got divorced because of disease, and also some situation ex-husband, ex-wife, and came back to help the patient to go through the difficult time. It's when you have a diagnosis of cancer, it's a challenge to all the relationship. And the health inequality might be more significant in cancer patients for the physician to witness. You know the difference, right? And I will discuss a little bit more. And also, the development of the new treatment is in the very astonishing speed, but that's also trouble for the physician. You have to learn all the time, right? You have to update. You know, the treatment could change every month, every year. So the re-education and also the burden, you know, a lot of documentation and electronic medical records. Actually, you know, the balance of the work life is to avoid a burnout is very important. You know, as a professional, actually, physician has the number 2 suicidal rate actually, and the physician burnout rate is very high. Also, most time it's 50%. You know, at some time, you know, more than half, close to half of patients experience burnout, depression. So that's why I always give advice to anyone want to pursue the medicine. You have to love it. You have to enjoy it. Otherwise, it's no fun. Actually, it's you will burn you down. So everyone welcome to ask any questions, and I will then move forward. And you know, I'm working on the blood disorder, leukemias. You know, basically all the blood cells actually and are from the hematologic stem cells inside the bone marrow. Then they can differentiate to the different cells, right? You know, from the stem cells, multi-potential stem cells, then they go to myeloid, lymphoid, and then you have all the cells inside your blood. But during the process, every step could be wrong, then develop a disease. And here is more, you know, myeloid, you know, from myeloid stem cells go to myeloblast, and then so each step actually you could have a mutation, then have a leukemia, the lymphoid also the same thing. So that's why when we talk about the hematologic malignancies, the lymphoid disease, that's myeloid disease, and ALL is very common in the pediatric, the most common leukemia in the pediatric population, but the cure rate is very high. So right now, the cure rate above 95%. You know, you just go through the very intensive multi-courses treatment. So CML is used to be a fatal disease, but right now has the BCR-ABL inhibitors. Actually, and it's a very, very curable conditions. You can live normal life. And the most challenging disease is the I'm treating is AML. So I think we'll discuss 2 cases, and so very some is curable, but the majority patients not curable with the chemo. They need a stem cell transplant. So stem cell transplant actually is the only cure for many high-risk hematologic malignancies, especially AML, MDS. MDS is pre-leukemia, they call the myelodysplastic syndromes. And I will show you the figure. Actually, the traumatic progress had been made in the past several decades, actually, but the disease relapse is still the major problem. This is the timeline for the stem cell transplant. You know, stem cell transplant started in Seattle by Dr. Donna Thomas, you know, in the 1950s. You know, it's a story there, you know, and when he just started, everyone laughed at him. You know, no one think he will succeed. You know, it's crazy you want to do this, but he persist. He did all the work, and no matter the people laughed at him, and eventually, you know, stem cell became like a standard of care for a lot of provide a cure for a lot of the leukemia patients, and also he won Nobel Prize. You know, a lot of medical progress actually started from was laughed by a lot of real experts at that time. Even the immunotherapy, right, is so hard, but when it started, you know, people think it's crazy idea. So that's why, you know, I tell the young students like you never be afraid of the experts. You know, experts could be wrong a lot of times in the history, right? But you can see the stem cells number increased dramatically until after 1980s because the supportive care early phase, a lot of patients just die. You can cure 1 or 2 patients, but until the 1980s, supportive care, conditioning, everything's improved, then became a real treatment modality to provide a cure. So you can see the number has been increased dramatically. That's the CIBMTR is Center International Bone Marrow Transplant Research. Actually, they recorded all the transplant done in United States and also international. Record all the transplant numbers and the outcomes. So in order to do the stem cell transplant, you have to find a donor. That's why you have some disparity. For the Caucasian, you have very high chance to find a donor. The first donor, best donor is sibling, right? Sibling, if the full sibling, each sibling 25% could be full match, the 50% half match, and the 25% not match at all. But you need to match the donor most of the time. And right now we can do a half match, right? But if we don't have sibling donor, we have to go to the registry. The registry have 30 million donors in the registry. For Caucasian, you have very high chance, 80–90% to find a donor. For Japan, actually they are very uniform. They have very high chance. But in the African American, even Asians, it only have a 20–30% chance to find a donor. So you can see the ethnicity plays some role in medical care. And we'll discuss a little bit the health equality. Is the attainment of the highest level of health possible for all the people? That's the eventually goal. But achieving the goal actually required everyone actually with a focus ongoing societal effort to address available inequalities. And there's a lot of injustice actually, and we have to eliminate some health disparity in the healthcare disparity. So the personal health is determined by many factors, right? There's your own factors. There's some genetic factors you cannot change. There are some individual lifestyle factors, but the social and community networks, and also, but there's a major part actually is the culture and the social, economic, and the environmental conditions. Next speaker actually give you more, actually, the factors that determine the health, 40% actually, there's some the gene actually involvement, you have some, there's some genetic conditions that you could carry from your parents, right? But that's only 10%. And there's some, environmental factors, and but 40% is like a social economic factors. Personal behavior contribute, like smoking and also eating habit also contribute to health. But actually clinical care, I think it's also played a major, in a certain area also played a very major roles, because now that everyone has an equal assessment to the patient care. So there's a structural inequalities, and most times from financial, housing, transportation, education, even social opportunities. And, so there's a structure in such way that they not benefit the population fairly. And especially there's a certain populations affected by the structural inequality most time, the minorities, American Indians, African Americans, children, and persons with mental health and issues, LGBTG population, immigrant refugees, and also rural areas, I think Hispanic populations. Structural rituals is the normalization of the area of the dynamics. There's historical reasons, cultural reasons, and also some institutional reasons. And most of the time, all these and the structures actually and provide advantage to the Caucasian peoples while producing like some cumulative and chronic adverse outcome for the people of color and other minorities. So that is an example, like a low birth rate, and in the by race, you can see in the white population, Caucasian is the different counties from a certain area is like 3 to 5%, but in contrast, and Black African Americans is much higher. It's a 7% difference. I will show you the recent data actually from COVID-19. Right, you can see the cases actually is clustered predominantly actually in the south and also the west area. So majority of these areas actually predominantly is African American and communities. You can see also the deaths by the zip code also, in the south side or the west side of Chicago, mainly actually the African American communities. So World Health Organization actually had some recommendation to promote equality within the health sectors. So first, we need to recognize the health sector is a part of the problem. So we have to prioritize the disease of the poor and deploy and improve services where the poor live, employ appropriate delivery channels, and reduce the financial barriers to healthcare, and set the goal and monitor the progress through the equality lens. So I think there's a long way for us. There's some social injustice and also have some healthcare and inequality we have to overcome. So next, any questions? Should we ask a question at the end, or Randall, do anyone want to ask any question about the professional and also any questions?
So there are a few questions in the chat. I can read some off and you can answer them right now if you'd like.
Yeah, I cannot see. Oh, here maybe. Okay, yeah, you can read any questions.
So one of the questions somebody asked is, how flexible are your hours as an oncologist, and do you have time outside of working to spend doing other activities?
Yeah, that's a good question. That's a difference between the academic and also private practice. I mean, the university is academic. The timing is more flexible. I have a 3.5-day clinic. I have Monday afternoon, Friday afternoon, Wednesday morning. I have to go to clinic. But all other, days, and I do have a lot of meetings. Like a Tuesday I have leukemia meeting. Thursday morning has a transplant meetings and all other, meetings. But beyond the clinic at the meeting times and the other times very flexible. If I'm not in the inpatient service, when you're in the inpatient service, I have to go to the ward and the hospital to run the inpatients and every day, and from 8 o'clock to the 12 o'clock every day. But that's a 2-week period. That's always a difficult time because I still have the outpatient clinic. The 2 weeks could be a challenge, and especially for the physician, they only have a couple of weeks, 2 or 4 weeks, and the inpatient service. That's always like a very stressful time. So in the academic, you do have very flexible schedules actually, and as oncologist, private practice is a different story. Right? Private practice, you just see patients, you're taking care. You have like most time a full day clinic, right? It's very busy actually, and you also have to see the inpatient. That could be very busy. That's a little bit different. It depends on which area, which setting you are going to.
Yeah, for sure. And another question somebody asked is, Chicago is a very diverse in race, socioeconomic status, backgrounds. And so did you find any correlation of results in your clinical study regarding this?
Yeah, that's also good questions. I think, yeah, Chicago has a lot of very diverse, has a lot, especially in Chicago, we are South Side. We have a lot of patients, African Americans. We did a lot of studies actually, for the cancer care. African American population still have worse outcomes, and from screening to the treatment into far less patient got the standard screening, and also far less patient got the proper treatment. I think there's even in Chicago, there's still a lot of disparities insist we have to overcome.
Yeah, for sure. And we'll just take one more question right now, and then you can continue with your presentation. So one question that somebody asked is, what do you wish you knew before you became an oncologist?
Yeah, so yeah, that's also good questions. I went to the medicine is not by my own choice. I was forced to because of my parents are all physicians in China. I think that's their expectation. I will be a doctor, so I went to the same medical school as my parents, right? So, but I think I thank them. I enjoyed the medicine as the professional. Take care of the patient. As oncology, I think yeah, we should. I think before I became an oncology, I had a lot. You go to the resident internal medicine, you have a choice to do what kind of the specialty. You can do the cardiology, GI, but I did a lot of research in the blood cells. Actually, that's why I have a strong interest in the blood. So, and that's why I choose the oncology and the hematology. I wish to know, I think one thing you want to know is the some emotional requirement to deal with the I got some classes actually during the residency, actually the education for the communication and also the deliver the bad news. I think in the recent years, the medical school started pay attention to that part. Actually, in our routine, we are doing this all the time. And as I told you, and most patients will die. At the end, most time you have to provide them some consultation, how to convince the family to go to the hospice care, palliative care. Like end of life discussion is a routine. I wish I know that better. Have more preparation to be an oncologist. I think in the future, if we can cure more patients, maybe you will deliver more good news. But right now, I think more than half the time, you have to deliver the bad news and end of life discussion. That's very important. And also the education in the past actually is not adequate to prepare the physician to do that.
Yeah, I agree. It must have been tough to, at first to learn how to deal with that. So
yeah,
we'll take questions at some point later in this presentation, so you can continue.
Okay, so I will just give you a case. Also, maybe I think I have to go back. Okay, here is the case study. It's a 50 years old man. Actually, it's pretty healthy. Actually, presented have several weeks. Actually, increased fatigue and also have dyspnea on exertion. You cannot catch breath while you move around, and that's why I go to see the doctor. On the physical exam, actually, is not remarkable, and you just feel the skin and also the nail is very, even the lip is very paler. Paler is like not red, like white. And but we did some lab, and the white cell count is very high, 64,000. Normal should be less than 10,000, but 64 is much higher. Hemoglobin is low. Normally for man should be 13.5, but 8.4. That's why I have trouble breathing, because the red blood cells carry oxygen to everywhere. And the platelet count is 33. Normally should be more than 150,000. It's much lower. Some patients could have some petechiae. I will show you a picture in the next case. And most astonishing features is 87 plus. Normally, the white cell count should be just neutrophils, half neutrophils, half lymphocytes, should be no blast. But 87, the blast is leukemia cells. So, we also do the chemistry, the creatinine is normal, so less than 1.5, liver fraction is also okay, but LDH is high. That's a very typical when you have a lot of leukemia cells, they have a high LDH, it's non-specific. And, and the uric acid is on the high side because the leukemia cells could die, cause tumor lysis. We did the EKG most time because a lot of drug can affect your heart. So, most of the time because we give some hydration, give allopurinol, try to decrease uric acid, to prevent the tumor lysis syndrome. Then we review the smear and also do a flow cytometry to see what kind of blast. As I mentioned, there's two types of leukemia, could be myeloid, could be lymphoid, right? And the treatment is totally different. And even in the myeloid, you could have, this must be most times acute, 87% blast must be acute leukemia. It could not be a chronic leukemia, but acute leukemia could be lymphoid, could be myeloid. So, so we send also the blood, for the cytogenetics. Cytogenetics is chromosome, right? Chromosome analysis. Normally, each normal person, each cell has 23 pair of chromosome, right? And for mine, it's 46 XY. For females, 46 XX, right? You got a half chromosome from the father, half from your mother. But when you have developed leukemia, you could have changes. You could have good changes, you could have bad changes, you could have no change. In addition to the chromosome change, right now there's a lot of gene mutations, could be also associated with the prognosis, also treatment. In order to make a diagnosis, we do the bone marrow biopsy. You just put the needles in the hip area, get some liquids out and take a small piece of the bone out. So here is the leukemia cells under microscope, very typical, and very large and has very typical presentation. The pathologist, they can tell right away under microscope. But we can also do some staining using antibody labeled. So most times they have CD13, CD33, CD34 is the marker for the stem cells. And you're not surprised, the whole marrow, the cells inside the marrow, we always use 100 minus your age. When you're born, the bone marrow is very juicy, 100% cells. When you're getting older, actually a lot of fatty tissue replace the stem cells. If you're 50 years old, the cellularity is 50%. A lot of empty space from fatty tissues. But when you have leukemia, all the proliferating leukemia cells fill the space. Most times 100% cellularity. So we do some mutation analysis. The mutation analysis will decide what kind of treatment we'll give, right? So this patient had the FLIP3 ITD, and we'll talk these molecules a little bit. And most of the time, this kind of patient actually cytogenetic is normal. Actually, they don't have cytogenetic changes. And so right now, as I mentioned, the AML used to be a single disease, but right now I will show you another slide. It's a multiple many disease and it has different features. And we classify them according to the cytogenetics, chromosome changes, molecular mutations, and put them in different category. And then most treatment for if the patient failed for the chemo, we give induction chemo, try to put in the remission. And as I mentioned early, most of the patient can enter remission, but they will not stay in the remission. They always come back. You have to give some consolidation, and sometimes you give a transplant in order to cure the disease. Here is the historical perspective of acute myeloid leukemia. We we know that for a long time, actually, Dr. Warsaw in 1847 already had generated the word leukemia, and but that we use morphology to make a diagnosis. Then recent years we use cytogenetics and molecular. Right now we use next generation sequencing and to have a better classification. The treatment also is initially we don't have a lot of treatment. So ALL actually, if you read the book, the cancer, the book history, actually, all the modern chemotherapy started ALL at the Dana-Farber actually, and so later we have some chemotherapies and some targeted therapies, and I will discuss a little bit some more targeted therapies, and the treatment changed dramatically. So right now the diagnosis, as I mentioned, we use morphology, we use the marker on the surface, and they call the immunophenotyping using the labeled antibody, especially CD13, CD33, CD34, and we use the chromosome analysis, and also we do the more sensitive phage to detect the gene translocation. And right now we also use the next generation sequencing to make a diagnosis. So here recently, that's the new development. For the leukemia patients, they have all the different mutations. Sometimes they have interaction between each others. As this patient we mentioned has a FLT3 IgD mutation. Actually, is the most common mutations in the AML. Especially has a normal karyotype. It's no chromosome changes. So according to the chromosome changes and also the mutation changes, and we put them in the different risk categories. They could have, especially for the, I delete one slide. I think we have favorable mutation is the chromosome change. So if you have A21 translocation involving chromosome A21. Also chromosome 16, version 16, that's also good. They call the core-binding factor leukemia. Is curable with chemotherapy, but they also have unfavorable. Most time you have the more than 3 chromosome changes, or you have a deletion chromosome 7, chromosome 5, and the 17p, all bad. But in the middle, basically you don't have changes. And between these patients, we use the molecular mutations to further define them what kind of risk they have. If they have a FLT3 mutation, actually here FLT3 mutated, actually it's automatically go to the unfavorable conditions. You can see they can separate the survival very well. And so right now WHO has a new classification AML. You can see the AML has a whole list, has different features. It's not a single disease, right? The treatment are also a little bit different. So as I mentioned, the treatment for the AML, if you are healthy, like the patient we presented, and we called the intensive chemotherapy eligible, the standard treatment is 7+3. 7+3 means one drug is given 7 days, continuous infusion. That's the cytarabine. The other drug is 3 days and a daily infusion, most times azacitidine, daunorubicin, idarubicin. This regimen has been there for 40 years, actually. And, for the young patient, the 70–80% chance you can enter remission. But for older patient, only maybe 40% of patient can enter remission. And that most time, induction just the first course. That if you enter remission, we have to give you some consultation. For good risk, you just finish consultation, no transplant. But intermediate risk, it's debatable. For the poor risk, even you enter remission, you got a consultation, you still cannot maintain the remission. You will have relapse. That's why you have to do the transplant. Without a transplant, everyone will have relapse. So, as I mentioned, 7+3 has been there more than 40 years. During this 4 decades, we try to add another agent to make it better. But by the end of the day, actually nothing, actually the third agent added to 7+3, nothing better than 7+3. That's why 7+3 has been the, there almost close to 50 years. We are still using that. But that's the new biology. We know the FLT3 actually is the surface molecules. Actually, they have actual membrane domains and can bind some ligands, and then they can transduce a signal to the cells to promote proliferation. And most times under control, the body secrete some ligands to tell them, but sometimes they have mutation. They have mutation here, like the tandem duplicate domain, they have mutation about 20-30%. This kind of cells, they just proliferate. Your body is not control anymore. They could have other mutations. And this kind of leukemia patients always presented with very high white cell count. Actually, like our patients, 64,000, because they are very proliferative. So we know that mutation, that we develop, some inhibitors, and not specific, but it has some efficacy against the FLT3 mutation. They call the methotrexate. Then we did some study, randomized them, right, to get the standard 7+3 with placebo, or the other part is 7+3 plus the methotrexate. That's the clinical trial we are doing on a daily basis, because we try to develop a better treatment, right? So the patient randomized to get the standard with placebo, the other is with a new agent added on, with induction, consolidation, then maintenance. You can see the outcome is better. CR rate is much higher. As I mentioned, most times 60-70%. Right now we increase from 66% to 74%, and also the survival is improved. Actually that's the first trial in the leukemia. We add the third agent to 7+3, actually has improved survival. Even most of the patients also want to transplant. Even you censored at the time of the transplant, basically you cut off and only count the patient who did not at the time of the transplant, still have a survival benefit, because otherwise people could argue, okay, it's more patient went to the transplant, that's why you have a better survival. So the question is, this patient has a FLT3 ITD mutation. That's why, for the new criteria, we'll go to the, high risk, adverse risk. But they could have exactly similar response rate with 7+3, but with better with methotrexate, because from 66% equals to 74%. But because that's a high-risk patient, we have to do the stem cell transplants, and also after transplant, we can do some maintenance to try to prevent the relapse, because even after transplant, relapse is still the major problem. And we do have other new agents, for the patient who had relapse. We do have the new agents to treat. I'll give you another case. That case is, I think Tricia found at online. I made a modify a little bit. This patient is 76 years old. Actually, is retired and has a lot of other medical problems, including diabetes and also amputation from diabetes, and also, was a performance status is not very good, and had to stay get a physical therapy in the acute rehab facility, and smoking, even quitted a long time ago, so there's a lot of other medical issues. And the patient also presented with some weakness and tiredness, headache, low-grade fever. So the physical exam, actually, here's a particular, because of low platelet count, you can see some, red spot. I think the figure showed up enlarged spleen, but to tell the truth, AML, most times they don't have enlarged spleen. And actually, it's the CML and MPN, myeloproliferative neoplasm, or the CLL, most time have enlarged spleen. For the acute leukemia, they don't. But there's a feature, actually, they could have a gingival hypertrophy, especially certain leukemia patients. Actually, other situations. So we had a patient had this changes and went to the dentist. The dentist just did some cutting. They didn't realize that's related to the leukemia. The patient not surprised. After that, the patient just had a dramatic bleeding. So this patient is a little bit different compared to the other case, and we made the diagnosis of AML of the bone marrow biopsy, but he's older with comorbidities, not fit, not a candidate for intensive chemo. What do you do? So recently, actually, just almost 2 years ago, actually, they approved a new drug, Venetoclax. It's a BCL2 inhibitor. Actually, during my research area time, I did a lot of work on the apoptosis, and BCL2 is the most important molecules to prevent the apoptosis. Actually, it's a combination with low dose and hypomethylation agent with this drug, and for the patient age more than 75, or even you are younger but you have other comorbidity, you are not a good candidate for intensive induction chemo, you can give this regimen. So this regimen actually is very potent. You can see the CR is complete remission. CRI is a complete remission, but sometimes it counts not fully recover. You can see the response rate is 70%. Actually pretty good. The most of the time they can enter remission after 1 or 2 cycles, and also you can see the survival. The duration of the response actually is almost 21 months, almost 2 years, right? And that's pretty good. So the curve, that's the Kaplan-Meier curve, survival curve. We want to see the straight line. Straight line means they plateaued. They are not have a relapse anymore. You can see, so far they still have relapse, and during the follow-up, and I think with longer follow-up, maybe they will stay there 20%, then just became straight. That would be good, maybe 20% secured, but we don't know. We need a long-term follow-up. So as I mentioned, the 7+3 has been the only treatment options for the AML patients, and for 4 decades. But since it changed, since 2017, actually, and there's 4 new drug approved for 2017, and additional, and 5 drugs approved for the in 2018. Actually, so right now we have a lot of targeted treatment according to the what kind of mutations you have. I don't have time to discuss IDH1, IDH2 mutations. Right now we do have a lot of options that we call targeted treatment. Yeah, that's all I have, because leukemia is a very specialized area. I don't think I now expect you to know all the information, and just give you some a little bit sense, the development. For AML, it's very typical story. We only have 7+3 for 4 decades, but in the past 5 years, 10 years, the field just changed dramatically. They have a new target come out. Even there are some immunotherapy, antibody, bispecific antibody, even the cellular therapy, CAR T cells. There's a lot of ongoing. So that's why it's a very fascinating field. 20 years ago, it's easy to treat AML. Everyone get a 7+3, right? You don't have other options. But right now, you have to do a lot of testing to find the best treatment for each patient. Each patient could be a little bit different. Yeah, so that's all from me, and I'm happy to answer any question.
Yeah, so thank you so much for your presentation. I think that this is one of the more detailed virtual shadowing sessions I've seen. So we've gotten a few questions in the chat. I'll start with the science-based questions because that is what we were just going through. So one of the questions is, have targeted therapies and immunotherapies have been more effective than chemotherapy in patient recovery?
Yeah, that's a good question. Yeah, so immunotherapy, there's one subset AML they call the P53 mutated. Most time have a 7p deletion. They are not responding to chemo at all. You can give chemo, the patient got the toxicity, they have a very low, less than 10% response rate. So in that case, rather there's a immunotherapy against the antibody against CD47 on the macrophage. Actually, to macrophage has the don't, CD47 is don't eat me signals, and the macrophage obviously clear some dead cells, foreign stuffs, but most times they don't kill our own cells because we give the signal, don't kill, don't eat me signals through the CD47. So, but right now they block that. Actually the outcome in the P53 mutated is dramatic. And right now it's like a 70–80% response rate compared to the 10% to the chemo. And also, the targeted therapy with BCL2 inhibitor with hypomethyl agent also, for the P53 mutated, we are not using the 7+3 anymore. For the IDH1, IDH2 mutated patients, for the older patients, they are not candidate. We do have leukemia patients, they are 80s. The median age AML is 70, right? And some patient could be 80s. We have a targeted therapy is oral agent, not even IV, so we can maintain the disease for a while. So I think, there's no question the targeted therapy changed the landscape of treatment dramatically.
That's really interesting, and it's really great to hear that new treatments are a lot more hopeful and provide more hopeful outcomes. So a follow-up question to that is, what are the primary side effects of targeted and immunotherapies?
Yeah, that's different, right? It has a intensive chemo, you cause hair loss, you cause drop, you have infection. But the targeted therapy, like IDH1, IDH2, sometimes they have they call the differentiation syndrome. I didn't mention the APL. APL is acute myeloid leukemia. It's a very fatal disease, but it's very curable. There's two agents, both agents from China. It's R1 arsenic. Right now, you don't need to chemo. Use these two. These two agents actually differentiate the bad cells to the normal cells, right? During the course, they have differentiation syndrome, because they induce the bad cells and from the leukemia cells to normal cells. Actually, it's very curable. So almost the cure rate is 98%. There's a couple percentages they die from the early phase bleeding. So the targeted therapy like IDH1, IDH2, later we found they have a differentiation effect. They are not killing the leukemia cells, they differentiate them to the normal cells. That's why they have a different syndrome. And the immunotherapy also has a different profile, right? They can cause the more anemia because this antibody also can bind the red blood cells and also the platelet. Sometimes it can kill your own red blood cells. You have to be very cautious. We start a low dose like a prime and give some transfusion, maintain the hemoglobin a little bit higher too. So immunotherapy can have some immune-mediated side effect. It's a new category, totally new category compared to the standard side effect from the chemo. Each drug has a unique side effect profile.
Thank you for that. That was a really thorough response. Thank you. So another question that we got is, how crucial is teamwork with other physicians and in oncology, and how has COVID-19 affected this?
Yeah, that's the most important. We are as a professional, we cannot work by yourself anymore. So right now, that's why we have the multi-discipline conference all the time. And no oncology can work by himself. You need at least especially for my part, I need the pathologist to help me to make a diagnosis. I need a pharmacist, to help me to adjust the medication dose. I need the social workers, case managers to arrange all the care, right? So that's a whole team. Right now it's not an individual you can treat the any patient. It's a whole team to treat the patients, including physician, nurse, and pharmacist, pathologist, the surgeon, and case manager, social worker, and also middle levels and coordinators. And if we will talk about the transplant, that's another group of people. And no one can work by themselves, right? Even the private practice is group. You have to have a very good relationship with other physicians, other area expertise. COVID-19 actually make changes, but we changed a lot of in-person visit to the virtual visit. All the meeting changed to virtual meeting like this one. So in the national meeting. So I don't think we compromise the patient care a lot. I think the physician we still go to work, and we know even patient has COVID-19. We cannot say no. We have to go to work. We have to take care of the patient. We cannot strike. Also, and there are some effect. And as I mentioned earlier, at the University of Chicago, more than a couple of months ago, I saw the data is more than 800 healthcare given, including physician, nurse, all the even care nurse and all other people actually take care of the environments, everything. More than 800 actually test positive for COVID-19, but we still go to work. Yeah, you have a quarantine, recovered for 2 weeks. Majority people still went back to work.
Thank you for that new perspective on teamwork in the medical system. I think that's definitely something that new students are working toward. And for the last question, somebody asked, what can we as students do to change the medical system and its institutionalized racism?
Yeah, I think from this election, I think we are facing very challenging time, actually, as American and United States, actually in general. I think long time ago, even the simple, to wear a mask is very difficult. But right now, the new president will require everyone to wear a mask. I don't know how. I think my feeling, the student actually already in the front line, and very open-minded. I think they are participating a lot of movement, including a lot of movement. Actually, they are doing a lot, actually. But I think the most important, you have to be aware of this, you're fighting for this, and also prepared for that. There's a lot of resistance, and you have to prepare yourself, and you cannot be very pessimistic, but also you cannot be very optimistic, and you think everything will change. I think the most important as a participation with the certain group, I think to in the long run, I think we need a little bit push from below, and eventually they have to make some change at a higher level, right? And to address the social disparity and everything. But I think, but at least, but I think from this election, I think even from my experience, actually majority, actually young generations, they are standing on the right side, more than the old generation. So I'm very hopeful for the new generation, actually, for the students.
Thank you. Yeah, I definitely agree. I think that our generation is a lot more accepting and open-minded. So hopefully that we can fight back against these inequities. Akila, do you want to go over like the quiz?
Yeah, sure. So thank you so much, Dr. Liu, for taking time out of your day to present for us. I definitely learned a lot, and I'm sure everyone here did as well. And we just posted the link in the quiz. I know it kind of got lost in the comments, but if you scroll up a bit, you'll find it. We're also going to email it out. So if you can take the quiz in the next hour, you'll be eligible for the virtual shadowing quiz, certificate, and we will be sending that out to everyone who receives a 2 out of 3. The quiz isn't too hard, it's just to see if you were paying attention. And we hope you attend our events in the future, and thank you so much everyone for coming out tonight and showing your support.
Okay, thank you very much. Thank you for the invitation. So